Our group has completed several studies now looking at the impact of providing financial rewards on health behavior in various clinical contexts. We recently completed a large-scale study among 878 employees at 85 GE work sites around the country, in which we randomized people to either get information about smoking cessation programs or information plus a package of incentives worth $750. We found that in the long term, at 9 to 12 months, that smoking cessation rates were triple in the incentive group what they were in the control group, so approximately 14.7 versus 5%. We also found that when we turned the incentives off, that the quit rates at 15 to 18 months, 6 months after the incentives were stopped, were 9.4 versus 3.6%. So the initial ratio of 2.9 at 9 to 12 months went to 2.6 6 months later. So it seems like there's good evidence for smoking that financial incentives can increase long-term cessation rates. We've done some similar work looking at obesity, in which we've developed different incentive systems that build more on insights from behavioral economics. So we provide frequent feedback in the form of rewards, where in one recent study, for example, among veterans at the Philadelphia Veterans Hospital, we randomized people to either get monthly weigh-ins, a lottery-based incentive in which they had a 1 in 5 chance of winning $10 a day, a 1 in 100 chance of winning $100 a day, or what's called a deposit contract, in which people could put their own money at risk between a penny and $3 a day. If they succeeded in meeting weight loss goals, they would win their money back plus a generous match from us. If they didn't succeed in meeting weight loss goals, then they would lose that money and it would go to a pool for people who lost at least 20 pounds. So in that particular study, everybody in the study had the same weight loss goal of 16 pounds over 16 weeks. And what we found was that the control group lost about 4 pounds, the lottery group about 13 pounds, and the deposit contract group about 14 pounds. We've also been doing some work on this in the context of medication adherence, and our work to date suggests that lottery-based incentives are also quite effective in that context. One of the challenges behind medication adherence for asymptomatic conditions is a lot of patients have trouble remembering to take their medicines, and in a recent pilot study we did of lottery-based incentives for warfarin adherence, we found that the rate of missed pill dosing went from about 23% pre-intervention to about 3% post-intervention. People sometimes ask me, why are we paying people to do things that they should do on their own anyway? And I think it's a really important question to address. What we do know is that people have a lot of trouble looking into the future and changing their behavior in ways that are important in terms of their long-term best interests. So for example, if we look at savings behavior, we see lots of examples of that with a very low savings rate. And healthcare is really no different, where a lot of people have trouble trading off immediate gratification for delayed and often intangible benefits. So what these reward programs do is they provide a mechanism for giving people positive feedback in the present, which help them do in the short term what's in their long-term best interest. The question then arises of, is this a good use of economic resources, because these incentive programs do cost money? And I think one thing that's important to acknowledge is if we look at the status quo, probably about 75 to 85% of Americans have health insurance where they basically pay the same premiums regardless of their health behaviors. And these are insurance products like Medicare, Medicaid, the VA, and most employer-sponsored programs. This, of course, also only applies to the insured and not the uninsured. But that said, we have these built-in subsidies in a sense that cover the cost consequences of people's unhealthy behaviors. And what the incentive programs can try to do is to try to offset that in ways which help people behave in healthier ways, because we bear the cost consequences of their unhealthy behavior decisions under the current system. I wouldn't go so far as to say, one question that sometimes comes up is, do these programs actually save money? And I don't think that's the right question to ask. The right question to ask is whether spending money on these programs is as cost effective or more cost effective than programs that insurers and employers currently are paying for to improve health. And I think that's the comparison we need to make. It's not a question of can we actually make money by doing this, because very few things in health actually make money. It's how should we best spend these dollars that we're spending to improve health, and is this at least as good as what we're currently spending money on now? Incentives are ubiquitous in everyday life for most Americans, and so even in areas like speeding, we see examples where behavior is largely affected by the incentives we face, because we know that if we drive too fast, there's some probability that we'll be caught speeding, and if we're caught speeding, we'll pay a fine. We think that incentives in healthcare also need to be aligned in favor of trying to encourage healthy behaviors. And it makes sense for us to think systematically not only about how we incent providers to provide better care, as opposed to strictly focusing on the volume of services that they provide, which is the norm now. We need to think about patients and their interactions with the system, and how do we try to steer them towards healthy behaviors as well.